Hello. Our group's topic is disc herniation, including laminectomy and spinal fusion. Our group members are Aldo, Priya, Madison, and Ava. First, we'll go over disc herniation. A disc herniation occurs when the nucleus pulposus is displaced from the intervertebral space. This usually occurs posterolaterally, and it ends up pressing on the spinal nerve, which then produces symptoms. The picture on the right is illustrating a herniated disc, also called a slipped or bulging disc, in the lumbar area. The picture displays the nucleus pulposus within the vertebral disc, displaced from the intervertebral space and compressing on the spinal nerve.
On this slide, we'll be discussing the anatomical structures affected by disc herniations. We're going to see structures between the vertebral bodies be affected, such as the intervertebral disc. This is where the protrusion or the herniation of the nucleus pulposus happens. It goes through the annulus fibrosus, which sometimes also affects the cartilaginous end plates, thus increasing the likelihood of compression on spinal nerve roots and the spinal cord. And we can also see the posterior longitudinal ligament also be affected by this, as herniations occur more posterior laterally, where the annulus fibrosus is thinner and lacks the support of the posterior longitudinal ligament. Cervical disc herniations, and the image on the right depicts a herniated disc in the cervical spine compressing on the spinal cord. Signs and symptoms of cervical disc herniations usually occur because of C6, C7 vertebral bodies, causing the most common complaints such as axial neck pain, ipsilateral arm pain, or paresthesia in specific dermatome regions. Axial neck pain usually causes pain in the neck due to mechanical stress or movement, such as prolonged posture or lifting something heavy. And then we can see radiculopathy occur, radiating down the arm from the herniated material, compressing the nerve root. And then sensory changes occurring, causing numbness or tingling in the arm or hand, motor weakness, weakness in the shoulder, arm, or hand muscles, and then myelopathy affecting the spinal cord, causing gait disturbance, hand clumsiness, hyperflexia, and spasticity. And then some red flags to be wary of is a fever, chills, night sweats, unexplained weight loss, unrelenting pain, point tenderness over vertebral body. Thoracic disc herniations, and the image on the right just shows a herniated disc in the thoracic region. Signs and symptoms of thoracic disc herniations are mainly asymptomatic and discovered by MRI scans. They present themselves with atypical symptoms such as pain, which would be dull and localized pain in the thoracic region. It would cause radiculopathy, pain radiating around the chest or abdomen, and then myelopathy causing abnormal walking or gait patterns, increased muscle tone, hyperflexia, progressive weakness and numbness in the lower extremities, and urinary and bowel dysfunction causing incontinence. And some red flags to look out for would be severe findings including gait disturbances, paralysis, and then cardiovascular abnormalities. Lumbar disc herniations, and the image on the right just shows a zoomed-in photo of a disc herniation in the lumbar region. Signs and symptoms of lumbar disc herniations mainly cause radiculopathy, sharp or burning pain, sensory changes, which is numbness or tingling, motor weakness, causing weakness in the muscles, and then limited trunk flexion because it's difficult bending forward due to the pain. And then it could also cause low back pain, and then pain exacerbation due to increased pain with activities like coughing, sneezing, or straining. And some red flags to look out for would be a fever, night sweats, unexplained weight loss, loss of appetite, extreme pain, and vertebral body point tenderness. And this image here basically depicts the nerve roots affected and the motor functions and sensory functions that are disrupted due to the nerve root that's being compromised. It'll be discussed later on in the slides, but here are some surgical approaches that you can do if you have a disc herniation. You can either approach with a spinal fusion or you can do a laminectomy. And lastly, here are some surgical indications of why you would need to potentially have surgery. You can either have failure of conservative treatment, constant symptoms despite doing PT, being on medications, or following other non-surgical interventions. You can also have progressive neurological deficits, increasing weakness, sensory loss, motor loss, and worsening urinary and bowel functions. And then you can just overall have significant pain, intolerable pain affecting your quality of life. Thus, you would approach it with either a laminectomy, which is basically the removal of lamina to decompress the spinal canal and relieve the pressure on the spinal nerve root, or you can do a spinal fusion, which is basically the stabilization of the spine by fusing two or more vertebrae.
Here I wanted to share some findings of recent research comparing conservative treatment versus surgical intervention for disc herniations. I had some quotes from the research that showed quick improvement with surgery in early stages when compared to conservative treatment. However, when compared to long-term, the results were the same, concluding that conservative treatment can be just as effective as surgery and hopefully avoid any surgical intervention in the future. Jay states patients who want relief from severe pain or who do not experience satisfactory outcomes with conservative treatment are more suitable for surgical treatment. However, for patients who are afraid of surgery or for older adults with comorbidities, conservative treatment is better than surgical treatment. It really just comes down to the patient's feedback, though sometimes surgery is required for patients that don't have their symptoms improved or movements improved within 3 to 6 months following with conservative treatment. Differentiating type of nerve compression. Here I wanted to talk about how disc herniations can have different type of compressions on the nerve. We have radiculopathy, myelopathy, and quadral equina syndrome. It's important to know what structures are affected from the disc herniation to rule out emergencies and ones that can be treated. There are different treatment plans for each case of nerve compression. However, surgical intervention is needed for quadral equina syndrome to prevent paralysis and incontinence. Radiculopathy is usually located at the neck or low back, while myelopathy can occur from all levels until L1 to L2, where the spinal cord ends.
Next, we'll go over laminectomy. Before describing laminectomy, let's discuss the lamina. The lamina are structures on the posterior aspect of vertebra in between the transverse process and spinous process. Lamina act to stabilize the spine and also to provide protection to the spinal cord and nerve roots. Lastly, the lamina increase in thickness from cervical to lumbar vertebra. A laminectomy is a surgical procedure where the entire spinous process and lamina are removed. This procedure is done with special care taken to preserve the facet joints, which are articulation sites for adjacent vertebra. The picture on the right is showing a lumbar laminectomy with a posterior and close-up transverse view of the lumbar vertebra, with the spinous process and lamina removed.
Laminectomy post-op. As a physical therapist, some precautions to follow is to avoid extension and rotations at the trunk, no lifting greater than 15 pounds, no sitting longer than 30 minutes. It's good to be up and moving and as frequently as you can and not laying down or sitting down for too long periods of time. And education here is the same as spinal fusions. It's bed mobility, positioning, log rolling, transfers, educating on posture, and teaching proper lifting techniques. Some early stages of exercises are some stretches, balancing, isometric pelvic tilts, and then for later stages exercises, we have upper body and lower body extremity strength exercises as well as glute activation.
Next, we'll go over spinal fusion. Spinal fusion, also known as spinal arthrodesis, is a surgical procedure where articulating bone surfaces of a joint are roughened and packed together with bone graft material. This leads to the formation of new bone, which then fuses the bones together. In this case, the articulating bone surfaces of a joint are adjacent vertebra. Spinal fusion is used to treat degenerative spinal diseases, like degenerative disc disease, and to correct deformity, stabilize painful segments, and restore lordosis and sagittal balance. There are many spinal fusion surgical techniques done based on location and pathology. The most common are posterior lumbar interbody fusion, or PLIF, transforaminal lumbar interbody fusion, or TLIF, lateral lumbar interbody fusion, or LLIF, and anterior lumbar interbody fusion, or ALIF. The image on the right is depicting a posterior lumbar interbody fusion where a laminectomy is done as part of the procedure in order to remove damaged discs and decompress the spinal nerves.
Spinal fusion post-op as a physical therapist. This protocol is almost the same as a laminectomy protocol, except the duration is longer for recovery from a spinal fusion due to the vertebrae adapting to the fusion from the levels affected. It's important to strictly follow the precautions for the full 6-week duration before adding movements such as lifting heavy objects, twisting, or bending.
Movement is medicine. Without it, we would all be losing essential muscle needed to perform the daily tasks and our ability to do things that we love doing. By maintaining proper circulation in the body through moving, this can all help us break down nutrients from a healthy and balanced diet, and also by specifically moving our spinal disc, this can increase hydration and diffusion within spinal disc. When we're talking about how movement helps disc, we want to talk about the promotion of Wolff's Law in the clinic or workspace with moderate and controlled loading. This would be done to promote progressive loading to make sure that the body continues to adapt to load it receives. Some examples of moderate to vigorous activity could be a fast walk or even gardening at moderate levels. When we're talking about damaging factors of movement, it is good to consider repetitive motions in lifting that cause damage to lacking structures. An example of this would be if you were to deadlift consistently with excessive curvature in the lower back, like the man in this picture, it could potentially result in a lumbar or thoracic disc herniation by not maintaining a neutral spine. Another thing to consider is that when the spine is not held in a neutral position and properly braced by the abdominal corset, this can lead to improper alignment of the body and opportunity for injury to occur. Too much load can also lead to compression of essential structures and potential disc bulges. If core stabilization is not active, this can lead to potential stress on the structures within the body that should be protected. Another factor that could contribute to injury is previous injury as well. You would be more prone to it. When we are considering the role of the PT in movement and disc health, the best forms of conservative treatment fell under methods of patient education, self-management, manipulations, mobilizations, exercise therapy, traction for short-term results, neuromobilizations, and epidural injections. And then a couple interventions that had some weak evidence was traction for long-term results and dry needling. And then there was a few that did not have any evidence, which were electrodiagnostic-based management, laser, ultrasound, and electrotherapy. Overall, in the Bowden articles found that little motion throughout the day would lead to reduced hydration and diffusion of the disc. In the Malik and Linsky study, it expands to say that minimal mobilization therapies and exercise can be more beneficial to patients than more invasive therapeutic interventions that physical therapists are able to perform, like laser, ultrasound therapy, and electrotherapies. It had also been addressed that epidural treatments can also be temporarily useful to address inflammation of affected areas. In the picture above, you can see halo traction being performed on a child. This would specifically be done to treat severely compressed spine or scoliosis.